Hello, friends. Welcome to the AORA4U Block of the Month series. I'm Dr. Javed from Indore, and today I will be presenting ultrasound guided costoclavicular brachial plexus block. These are some learning objectives of this block. All credit goes to Professor Manoj Karmakar from the Chinese University of Hong Kong, who in 2015 described this costoclavicular space and the costoclavicular block of the brachial plexus. Costoclavicular brachial plexus combines the benefits of real-time ultrasound visualization of the plexus and the needle and targeted delivery of local anesthetics to the nerve and thereby preventing injury to the blood vessels and pleura. So let us start with the brachial plexus. What is the brachial plexus? A group of nerves that use motor and sensory innervation to the upper limb. Now, what are the components of brachial plexus? Roots, trunks, divisions, cords, and branches. Roots are formed by ventral primary rami of cervical 5th, 6th, 7th, 8th, and thoracic 1st. When it is combined with C4, it is prefixed, T2, it is postfixed. These primary rami, they unite to form C trunks. C5 and 6 join to form the upper trunk, C7 form the middle trunk, C8, T1 form the lower trunk. Each trunk divides into two divisions, anterior and posterior division. These divisions eventually unite to form cords. Anterior division of upper trunk and middle trunk, they form the lateral cord. Posterior division of all these trunks form the posterior cord, and the anterior division of lower trunk continues as medial cord. They are in relation with the subclavian artery or the first path of axillary artery. What is the site of the brachial plexus which is blocked at the costoclavicular space? It is at the level of cords, lateral, medial, and posterior cords. If you look at the midpoint of the clavicle in the infraclavicular fossa, there is the point where the costoclavicular brachial plexus block is given. This space is bounded anteriorly by the subclavius and the clavicular head of pectoralis muscle. Posteriorly, it is bounded by anterior chest wall and serratus anterior muscle. So beneath the clavicle, midpoint of the clavicle, these cords lies in relation with the axillary artery where the block has been done. This is the area of medial infraclavicular fossa. At the level of clavicle, you see the brachial plexus is, if you can imagine hourglass appearance, this is the narrowest part of the hourglass is at the level of clavicle. It has certain advantages as a significant space. Indication of the block, any of the analgesia, anesthesia of the upper extremity excluding shoulder, patient's diffusal, local infection, a patient on anticoagulants, allergy to local anesthetic, they are the absolute contraindications. While a patient with pure neurological deficit of the arm, chronic obstructive airway disease, and the controlled paralysis of the phrenic nerve or recurrent laryngeal nerve, they are the relative contraindications. Pre-optimization of the patient with a pre-anesthetic checkup for any of the comorbid conditions is to be done. And when the patient is taken in OR, procedure room, a proper intravenous line, all types of monitoring, anesthesia workstation for plan B in condition of block phase, PNS ultrasound machine stimulating needle, and local anesthetic are to kept ready. Last but not the least, intralipid 20% to counteract any of the last. Position of patient is usually supine position with the 90-degree abduction at the shoulder joint and 90-degree flexion at the elbow joint. As we are targeting the superficial structures, so a high-frequency linear array probe is required. If you are at the head end of the patient, then the ergonomics should be that the ultrasound machine should be on the ipsilateral sides towards the axilla. But if you are operating from the distal end, then the machine should be on the head end of the patient. There has to be angulation, cephaloid angulation of the probe below the clavicle so as to visualize the plexus clearly. Usually the direction of needle is from lateral to medial direction. If you look at the sonor anatomy, from anterior to posterior, we'll find pec major muscle, small subclavius muscle. Laterally, there will be the interior muscles. Medially, the intercostal muscles, second rib. And you look from the medial to lateral, there's a axillary vein, axillary artery, and lateral to that, brachial plexus containing lateral, medial, and posterior cord. These cords are arranged in a triangular structure. So this is the plexus. Now, what will be the point of injection of local anesthetic into the plexus? Going from the lateral to medial side, if you are opting for a single injection, needle has to be between the three cords. A certain volume of the local anesthetic is deposited, which will take care of all the three cords. But if you are going for a multiple or a double injection, then the needle should come from the lateral to medial side into the posterior compartment. Certain amount of drug is deposited there. Then the needle is redirected anteriorly to the anterior compartment so as to block the lateral cord. We advocate a multiple injection to all the cords. If you are doing with the dual technique, then motor response should be noticed. Stimulating the lateral cord will get the flexion of the elbow, finger, and flexion and apposition of the thumb. Stimulating the medial cord will get the flexion of the first 3.5 fingers and opposition of thumb, while the stimulation of the posterior cord give rise to extension of elbow, wrist, finger with the abduction of thumb. The patient is properly positioned, optimized. Then before going for the proper procedure, final procedure, a cord scanning is to be done, and all the three cords, plexus has to be identified. We advocate a multiple injection. So look how we proceed for the block. You can see the artery on the extreme left of the screen. Needle is introduced going to the anterior compartment, and local anesthetic is instilled to block the lateral cord superficial to that. There has to be 2 to 3 ml of allocates of local anesthetic with proper aspiration each time. Now, the local anesthetic is instilled into the lateral, just beneath the lateral cord. After that, needle is redirected, just withdrawn and redirected into the posterior compartment so as to go into the posterior side of the posterior cord. This is the drug which is deposited into the posterior side of the posterior compartment. Then one more injection has to be there in between the lateral and the posterior cord. The whole idea is that the whole of the plexus or the cords should be bathing in local anesthetic solution. See, this is a picture after complete installation of the local anesthetic. Now the block in costoclavicular block in a pediatric patient with dual technique. This is the 8-year-old boy with fractured elbow taken for costoclavicular brachial plexus block with dual guidance. First, we'll do the scout scan, and you can see this is the vein, this is the artery, and whole of the plexus lying in a linear fashion. This is the lateral cord, medial cord, and the posterior cord. You can see a distinct septum in between the lateral and the medial cord and the posterior cord. So the scout scan is done before going for the final procedure. Going medially to ensure the pleura and the lung. Now the main procedure. 5 centimeter stimulating needle is introduced from lateral to medial side into the superior compartment or anterior compartment just beneath the lateral cord. 2 ml of the local anesthetic is instilled. You can see the spread of local anesthetic around the lateral cord. The needle is redirected into the posterior compartment. Again, 2-3 ml of the local anesthetic is instilled into the posterior compartment. That is how the whole of the plexus is now bathing into the local anesthetic solution that ensure a quick onset and complete block. Before installation the local anesthetic, stimulation is given and motor response is noted. You can see in this video stimulation of the medial cord, lateral cord, and then the posterior cord. This is the medial cord, lateral, and this is the posterior cord. After confirming at a lower current, local anesthetic is instilled. A total of 12 ml is given. Regarding the dose of local anesthetic, a mixture of 30 ml of the local anesthetic is prepared, out of which lignocaine 2% with adrenaline is 15 ml and 15 ml of bupivacaine 0.5% or ropivacaine 0.5%. The volume in adult given is 15 to 20 ml, in pediatric patients is 10 to 12 ml. Adjuvant dexamethasone 4 mg or 8 mg by far the most benign, doesn't cause bradycardia, hypertension, and sedation. You are attempting for a costoclavicular brachial plexus block. Upon putting the probe, you find such a picture. One of the vessel is coming from the lateral side to medial side or the plexus. What is it? And sometimes you will get some arteries coming up from the axillary artery. So that was the cephalic vein which is running into the axillary vein, and this is the trunk of the thoracoacromial artery. Why this happens? Because your probe is in the caudal direction or perpendicular. If you angle your probe in the cephalic direction, you will get a proper visualization of the plexus, and that gives a 100% effect with no complication. This is how cephalic angulation helps improving your block. Most of the time we are going from lateral to medial direction in the costoclavicular brachial plexus block. But sometimes there will be some hindrance in negotiating needles because of this required process. So what has to be done in this case? You can go from medial to lateral side, avoiding injury to the axillary artery and vein, and can instill the drug into the plexus. It's also possible and fruitful. Costoclavicular versus supraclavicular. In the costoclavicular approach, we are approaching from caudal to cephalic, peeping the brachial plexus from beneath the clavicle, while in supraclavicular, we are peeping into the plexus from cephalic to caudal direction. So what is the difference of the sona anatomy in these two places? See, in the costoclavicular space, the plexus, the cord they're condensed into a small space, compact space. There's more neural tissue and less connective tissue, and it is far from the pleura. While in supraclavicular, the area of the plexus is large because of more connective tissue, and they are very close to pleura. So if you instill a small amount of drug at the costoclavicular space, there has to be a rapid onset of the action of the block as compared to supraclavicular. Volume required in narrow space, compact space will also be less as compared to supraclavicular. And as we are using this low volume and going distal to the far distal to the phrenic nerve, chances of heavy diaphragm in this block are very rare. And as we are going in the, far away from the pleura, the chance of pneumothorax are very less. A randomized observation study by T. Shivashanmugam regarding the ipsilateral diaphragm after a supraclavicular and costoclavicular brachioplexus block, what he finds, the incidences, the percentage is much less in costoclavicular as compared to supraclavicular block. Costoclavicular versus infraclavicular. We are looking at the costoclavicular space. All the three cords are arranged in the lateral to the artery. We're going from costoclavicular to the lateral intraclavicular fossa. There's anti-clockwise rotation of the cords so that the median cord comes in between artery and vein. Posterior cord at 6 o'clock position of the artery and lateral cord is at 9 o'clock position of the. What is the relevance of this anti-clockwise rotation of the cords? You can look at the sonotomy. This costoclavicular space is small compact space while the infraclavicular space is large and a deeper space. It has consequences. So if you are doing infraclavicular, it will be on the much depth because we have to cross two major muscles, to pec major and pec minor muscles. Depth will be more than the costoclavicular. Volume required to block the three cords will be more than the costoclavicular approach, and the effect onset of action will be slow as there is a lot of connective tissue. Drug take a long time to disperse. So the costoclavicular approach is much better than infraclavicular approach. A prospective randomized comparison of the infraclavicular and costoclavicular approach done by Manoj Karmakar, and they found it the time of complete analgesic block is less than in costoclavicular than the lateral sagittal infraclavicular approach. A study is done by Sebastian Lyra about the single versus a double injection, and what they found, with the double injection there is a shorter onset of time and time required for complete analgesia is also less in costoclavicular. Manoj Karmakar did a research by using high definition ultrasound imaging, and what they found, a single hypoechoic septum they extend laterally from the axillary artery, dividing the compartment into anterior compartment which contains the lateral cord and the posterior compartment containing posterior and medial cord. It has a clinical significance. One more studies, it also shows there's a facial septa between the two compartments. So they advise two separate injection to get a proper effect and better effect. See, this is the anterior compartment containing the lateral cord and the posterior compartment containing the medial and posterior cord. So we advise to go for a multiple injection and be sure that all the three cords are completely surrounded by local anesthetic to give a better effect and better result. Virendra Koyalamudi, they did a cadaveric study. What they did, the 5 ultrasound guided costoclavicular blocks injections were performed in cadavers with 20 ml of 0.1% methylene 2. And what was the result? The dye extended cephalite to the level of the cricoid cartilage in the 2 of the 5 injections. 3 injections had dye extending 0.75, 1.5 to 2 centimeter chordate to the level of cricoid cartilage. And the C7, C8, T1 nerve roots are stained with all in all the time. It's stained. And the dye didn't extend cephalite to the C5 and C6 nerve root. That is a welcome sign. All the trunks, cords, and divisions of the brachial plexus were stained, and as the suprascapular nerve. But the most important thing is there is no spread of the dye in the phrenic nerve in any of the specimen. So this block, this is much comfortable as in regards to phrenic nerve involvement. A randomized control trial by Bhumi including 80 patients who received injection of 25 ml of 0.375% of ropivacaine, demonstrated that the costoclavicular space block reduced the incidence of diaphragmatic paralysis to 3%. Alice et al. Reported the zero incidence of phrenic nerve block using 20 ml of 0.5% ropivacaine for costoclavicular block injection. Now, this is an article, a study, which signifies the costoclavicular brachial plexus block reduces the hemidiaphragmatic paralysis versus supraclavicular block. What is the result? There's only 2.5% of the in the case of cases in costoclavicular as compared to 39.8% in supraclavicular. The study regarding the minimum effective volume of lidocaine for costoclavicular block is found to be 34 ml. And one study done by Manoj Karmakar and colleagues of minimal effective volume of 0.5% ropivacaine turned out to be 20.92 or almost 21 ml. In one study, it is found 19 ml of 0.5% ropivacaine at the minimum effective volume. There's a study of comparison of ultrasound guided costoclavicular and supraclavicular brachial plexus block. The result was that the costoclavicular is a safe and efficient approach for upper limb extremity surgeries. And there's a comparison of the costoclavicular block with supraclavicular brachial plexus block. They have found that this costoclavicular has a shorter procedural time and rapid onset of sensory and motor blockade as compared to supraclavicular brachial plexus block. There's also a randomized comparison of intrascalene and costoclavicular for orthoscopic shoulder surgery, and what they found is that the postoperative analgesia is equivalent, but the risk of hemidiaphragmatic paralysis is less in costoclavicular approach. A brief technical report given by Manoj Karmakar and the team. What they find is novel technique of costoclavicular block at the intraclavicular space has a rapid onset of action as compared to the other techniques. One more study, a systemic review meta-analysis of infraclavicular versus costoclavicular approach, ultrasound guided. They found the equal sensory and motor block as compared to the classic intraclavicular approach for adult patient, and similar rates of block failure and complication between the two techniques. Some acknowledgements to the stalwarts, Professor Manoj Karmakar, RAPM, Naisora, Kachinchin, Dr. Vincent Rock, and Dr. T. Shivashanmugam. Some references. So the costoclavicular brachial plexus block is a useful approach in terms of rapid onset, a dense block, predictable anesthesia with high success rate and low complications. Thank you so much.